So thank you very much, Akiva, and all of the members of the Hyper-IgM Foundation. It is a pleasure to be here, and actually it's my first time that I present on patient association meeting. I have been to EPOP meetings for 2 or 3 times. But I would say that this meeting is completely different. It's absolutely patient-centered, and it is a pleasure. I love talking to patients, and additionally, on behalf of Latin America, I would like to thank you for inviting a person from Latin America, and I will make my best to connect our patients to this patient association to make it global. Because as you will see, Latin American patients have a different phenotype because of environmental pressure and other considerations that I will tell you. They have different stories. First of all, I would like to exercise everybody that primary immunodeficiencies are a group of many diseases, almost 400, and everything can be a primary immunodeficiency. This is an area of the medicine, it's recent. And actually, what we are used to listen is that patients with primary immunodeficiency have recurrent infections. So susceptibility to infections, that's true. This is the way how the field of primary immunodeficiencies started. But afterwards, with the technology of genetic sequencing, the evolving of immunological mechanisms, and everything else put together, patients with primary immunodeficiency may have lack of regulation, so they may develop extremely allergic phenotypes, may have autoimmune diseases, autoinflammatory diseases, and may have a susceptibility to cancer. So deficiency means lack of something. So lack of protection against infections, lack of protection against cancer, and lack of regulation. So once you don't have regulation, if you are driving a car and you are pushing too much and you don't have brakes, it will crash. So then is when you have the allergy and the autoimmune and autoinflammatory diseases, okay? So you may have a lack of brakes. So this is something that we always tell clearly to doctors, and it is important for you as patients to know about this. About hyper-IgM. So this is a fancy cartoon. It's very current. It was published a couple of weeks ago. And it will bring all of the possible forms of hyper-IgM. So the one that we know most is the CD40 ligand interaction. Actually, here in the right, you have the T cell. On the left, you have the B cell. The B cell is the one that produces antibodies. The T cell is the one that will regulate. It's the maestro, the conductor of the orchestra. So the T cell will decide everything for us. So as the T cell expresses the molecule called CD40 ligand and interacts with the receptor in the B cell, CD40, it will give a signal to the B cell to make what we call the class switch recombination. So the cell will not only make IgM, but it will be able to do IgG, IgA, and IgE. Afterwards, other molecules were described related to the class switch recombination. I would say AID, UNG, these are traditional ones. But then afterwards, many molecules are involved on that. So currently, we will have many forms of patients, many patients that may show up with hyper-IgM, but they are not necessarily CD40 ligand deficient. So I will highlight because CD40 ligand disease is the most frequent one, obviously I will focus more on this, but I will briefly show you about the other forms. So here are the clinical picture of CD40 ligand. So this is X-linked disease, means that the gene involved is encoded in the X chromosome. So originally, what we should expect is that the mother is the carrier, and the mother will pass this defective X-linked gene to a male child. Okay, so this is the most frequent form. It is interesting to stress that, highlight that patients with X-linked hyper-IgM disease, they will present with recurrent infections. Okay, but then we would like to classify those in infections caused by extracellular agents. I would say, so these are bacteria, for example, the pneumococcus that will give pneumonia. So for this kind of bacteria, it is very important the presence of antibodies. So it is necessary to have IgG and IgA to opsonize those cells, principally IgG. So once the pneumococcus is opsonized, is covered by IgG, it will be much easier to phagocyte those pneumococcus and kill it by neutrophils or macrophages or whatever. So X-linked hyper-IgM patients will have those kind of common infections. However, because of the lack of interaction of the CD40 ligand molecule with the CD40 in the myeloid cells include neutrophils, monocytes, macrophages, dendritic cells. So those kind of patients will also have infections by what we call intracellular pathogens, for example, fungus. Here in the United States, the Pneumocystis jirovecii is a very important species. Okay, so that's why X-linked hyper-IgM patients get Bactrim as a prophylaxis, is to avoid that kind of infection. So in practical words, X-linked hyper-IgM will behave like a form of combined immunodeficiency that will affect both sides of the immune response. Other frequent problems will be on the gastrointestinal tract, on the biliary tract, on the liver, because of infections that may occur in there. And then other complications like central nervous systems, neutropenia, autoimmunity, etc. For our patients in Latin America, because of the tropical weather, they may complicate with aspergillus, tuberculosis, have side effects of BCG vaccine, and with blastomycosis, which is a form of systemic mycosis that is endemic in South America. Patients with, is there any CD40 receptor patient here in the audience? No?
Not that we have in our group.
Yeah. So they will behave more or less like the CD40 ligand deficient, because the connection will not work, okay? And for the others with AID and UNG, it will affect mainly the class switch recombination antibody. So the patients will present with hyper-IgM, but it will not produce IgG or IgA. So then it will behave predominantly with extracellular infections, bacteria. So it's more a B-cell disease. So I will go further, then I'll be back again for the X-linked hyper-IgM. So I will list you other, just show you that those diseases exist. So The NF-kappa B pathway can be affected. NF-kappa B is a pathway that is very important to activate the immune cells, all of them, lymphocytes, B cells, T cells, and myeloid cells. So they may show up with hyper-IgM, but actually it's a completely different picture. The patients will show up with ectodermal dysplasia. They cannot sweat, they don't have hair, they have conical teeth, so it's a completely different disease, okay? And patients that will have problems with molecules that will repair DNA. So those patients are susceptible to have cancer. It's a very high susceptibility. And here there is the classical HIGM mutation that gives to the ataxia telangiectasia syndrome. But some of those patients may present with hyper-IgM. Other molecules connected with the DNA repair. Here we have the PIK3C delta APDS syndrome. We have one patient here, one family with this disease. So those patients may present with hyper-IgM. Not all of them, but some of them. So what happens is that this pathway may be affected, the molecule presents with a mutation that will hyperactivate that pathway. So the patient will have an inflammatory syndrome, will have recurrent fever and recurrent situations that will simulate like an infection, but it's actually only inflammation. However, the capacity to produce antibody is affected, and the patients will have recurrent infections. And some of them may present with hyper-IgM, okay? And the patient will also present with, may present with lymphoproliferation, so adenopathy, the enlargement of liver, the spleen, etc. I have one adult patient with that syndrome. It's a woman about 50 years old, but she does not have hyper-IgM. She has a completely different picture compared to your family. It's another case. So we have to open our eyes. There are those forms of ICOS defect, CD19. So generally, ICOS and CD19 are patients that are classified among the common variable immunodeficiency group, but they may present with hyper-IgM. Okay, so this is something that and these are the other forms. So some of them are classically recognized as either B-cell defect or combined immunodeficiency defect, but they may show up with hyper-IgM. Then it's up to you guys of the hyper-IgM group to decide how to deal with these situations, because once the scientific knowledge advances, if you're going to accept those guys in your group or not, how to test, how to prove, how to make the genetics, because it's a different, a completely different approach. So the needs, for example, for ataxia telangiectasia patient is completely different from an X-linked hyper-IgM. So ataxia telangiectasia is not transplanted, never. So depends very much on how you guys are going to manage the group. But some of them will show up clearly with hyper-IgM. And they will obviously seek assistance, look for you to help them. So talking about our classics, so now I'll give some time to our CD40 ligand, CD40, which is the classical one. So the interaction of those molecules, the T cell will express the CD40, the B cell will have the CD40 receptor. It is necessary for that signal to come out, and the B cell will be activated. So this is the classical knowledge. But look at this cartoon. Here you have the dendritic cell. So it's an antigen-presenting cell. What the cartoon is not showing is that the T cell and the dendritic cell, the T cell also shows CD40 ligand to the dendritic cell that has a CD40 receptor. So there is an interaction between T cell and dendritic cell. The T cell releases interferon gamma. So if this interaction does not happen, if you have a problem here in this communication, the release of interferon gamma is affected. Interferon gamma, and the other interferons, are crucial for the protection against intracellular pathogens. For example, virus, protozoans, and fungus, and intracellular bacteria, for example, tuberculosis. Okay? So the interferon gamma pathway is affected in this form of the disease. So it's not only about class switch recombination. What kind of mutations can happen? All types. Okay? You can have what I say, the missense when you have a substitution, nonsense when you absolutely kill the molecule. So all of the others, okay? So I'm not going into detail, but most of them will affect the outer part of the molecule, is the part of the molecule, so you have an intracellular part, a membrane part, and outside part, okay? It is this outside domain that will interact with the CD40 receptor. So most of the mutations affect this outside part of the molecule. So in some patients, you may test, so you have the hyper IgM, and you test for the CD40 ligand. This is important to say. You have to learn that. So here, the T cell will express the CD40 ligand. So most of the mutations are here in the outside, okay? So you have the hyper IgM, you have a boy, so it looks like X-linked. And you do the flow cytometer test, and the molecule is there. The CD40 ligand is there. And so what? What kind of hyper IgM syndrome do you have? You have the hyper IgM, is a boy, the clinical picture matches, and the CD40 ligand molecule is there. So there are some mutations that will still keep the CD40 ligand molecule there in its place. However, because of the mutation, although it's there, it does not work. So it is important to do the final test that you have to test the CD40 receptor and you have to test both together. Okay? These are all flow cytometer tests. I'm quite sure you have them available here in the United States. Well, everything that we set up in São Paulo was actually learned from Seattle, from Hans Och's group in Troy. So we are a very connected collaborators. So what I have in my lab is a copy of Troy's test. So it is very important this. So I'm sure Troy does it. We learned from him. You have to test if they eventually work. This is the collection of patients in Brazil. It was published in 2014. Now we have more. So actually, as you see, it's a big group. Akivas is 35 patients. Okay, and there are others. In Argentina, Mexico, Costa Rica. So these statistics now will be updated for Latin America, and we have, and as a typical X-linked disease, this is the expected of novel mutations that may occur. So we have them. So these are the kind of infections that we have to face there. So let's take for the regular bacteria, so Streptococcus pneumoniae, Staphylococcus aureus, Pseudomonas, Klebsiella, Actinobacter, Serratia, E. coli. So this is something that you already know. The Pneumocystis jirovecii, you are already used to it, however, the others no. You see? C. albicans, Aspergillus, okay, Microsporidium you have, but Paracoccus you don't have, Histoplasma you don't have, and Cryptococcus also you don't have. Mycoplasma pneumonia, we got tuberculosis. We got 3 cases. Cytomegalovirus, hepatitis B, herpes simplex, molluscum, HPV, parainfluenza. Giardia is a frequent problem for us. The Cryptosporidium, and Isospora. Isospora is also a very difficult situation. So these are the pedigrees of some of our families. As I told you, sometimes the diagnosis, sometimes no, most of the times the diagnosis come very late. Look at this family. How many people died before we get a diagnosis? So we still have to do a lot of education and awareness. You see? So many deaths before diagnosis. So here are some examples. The Paracocci, this boy, you can see, it's a very severe case. This boy had 15 years old, 1-5. And about 25 kilograms of body weight, so it's almost nothing. He didn't survive. A case with TB, Candida, Aspergillus. This boy with AFTE because of the neutropenia. I managed to remove the sound, but was unable. This patient had an infection of Mycobacterium marinum in the skin. It's a kind of tuberculosis in the skin. And he got this infection because he liked to play with the aquarium, with the fish. Okay, Mycobacterium marinum is a kind of bacteria that will survive in water environment. So perhaps it's a recommendation for those patients not be playing with aquarium and not having them at home. Okay, we had this experience. So what are the non-infectious complications? Neutropenia is by far the most frequent of them. At least half of the patients will present with neutropenia sometime of their life. GI tract complication, aphthous ulcers, anemia, sinopulmonary infections, sinopulmonary. So you have all types of possibilities. So, in summary, X-linked hyper-IgM mutations or CD40 mutations, AID and UNG are the most frequent forms. More recently, the NF-kappa B pathway, and then other more recently described molecules. And then you guys will have to think about how to deal with these subgroups. For the hyper-IgM, you have the recurrent bacterial and opportunistic infections, very low level IgG, IgA with normal or high hyper-IgM, apparently normal T and B lymphocyte counts, impaired germinal centers. So as you do a biopsy of the lymph node, the architecture is not organized as a normal control. The hypermutation, somatic hypermutation does not work, so the patient cannot make antibodies properly. The complications is pneumocystis, cryptosporidium, the liver disease, the neutropenia, abdominal tumors related to the biliary tract, some patients with neurodegeneration, and some patients with pure red cell aplasia. I never had patients with this, but they may occur. Evidence suggesting broader T-cell dysfunction is pneumocystis pneumonia, cryptosporidium, and lymphoid hyperplasia malignancy. Okay, so I would like to stop here and collect some questions, then we can go to treatment. Would you like to make questions, discuss any points, to wake up people from the lunch? So once we had a previous conversation here before the meetings, you can see that the picture of the classical hyper-IgM is absolutely different from your family. So what you have is a dysregulation of the immune response, and the boy has hyper-IgM phenotype, but the immune system of him works on a completely different way. So then it has, besides the immunoglobulin, there are specific medications that can be given to him. I love this question. It's exactly my question, and that's why I'm studying the phagocytes. So stay here by 4:30, and we're going to see the answer. That's my question. It consumes my liver, okay? So this is the precise question. So you have the hyper-IgM, you have low immunoglobulin levels, you replace with immunoglobulin therapy, and anyway, the hyper-IgM patients continue presenting with infections. Why? Then I'll tell you the story. You have to be here to listen. Okay, treatment considerations. We have written a review recently, and it was published. I can send you the PDF, so I will summarize this story. So what this graph shows, this cartoon, you have here primary lymphoid organs. Primary lymphoid organs are where the immune cells will grow and differentiate, okay? So it can be from the lymphocyte lineage on myeloid lineage. Lymphocytes will give rise to T and B cells, and myeloid cells will give rise to neutrophils, monocytes, dendritic cells, macrophages, otherwise. In other words, the phagocytic cells. So they eat bacteria, protozoans, fungus, etc. T cells will release CD40 ligand, will express and also release CD40 ligand in order to activate the B cells, but not only them. They will activate also the myeloid cells. And this has been proven previously in basic immunology studies with mice, the relevance of CD40 receptor activating to activate properly macrophages, dendritic cells, and neutrophils. Okay? The absence of CD40 ligand results in respiratory disease, GI tract disease, central nervous system, and predispose to neutropenia and sometimes cancer. So what we have to do? On a suspicion of a CD40 ligand deficiency, you go to the diagnosis, you evaluate the CD40 ligand expression and function. as I told you, it's not only a matter to run a flow cytometer to look at the CD40 ligand molecule. Sometimes it is there but does not work, so you have to make the functional approach. So that Otávio, my former fellow, learned clearly from Troy lab. So we have that kind of assay, and it's very important to do it. So if you have it normal, you will investigate other diseases. There are several other forms of CD4 of hyper IgM syndromes. If you have reduced or absent, you can go to the genetic analysis of CD40 ligand. And once you have it, it's a mild phenotype or a severe phenotype. Immediately start treatment with antibiotic, immunoglobulin replacement, and basic hygiene measures. Okay? If you have a severe phenotype, you have to consider the bone marrow transplant. If you have neutropenia, you have to replace with GCSF as growth colony stimulating factor to rescue the neutrophils. The interaction of CD40 ligand, CD40 is important inside the bone marrow to develop properly neutrophils. So, the clinical findings may be upper and lower respiratory tract, gastrointestinal manifestations, central nervous system problems, malignancies, autoimmunity, sepsis. Immunological findings, defective class switch, neutropenia, defective memory T cells, low production of interferon gamma. So this starts to respond your question, okay? So why you keep continuing having infection? Because the intracellular pathogens are not covered by immunoglobulin replacement therapy. Then you have defective neutrophil maturation, defective macrophage maturation, and defective dendritic cell activation. The treatment, immunoglobulin replacement. So these are the regimens. I think you are very used to this. It can be sub-Q or it can be intravenous. Bactrim is a very popular antibiotic to be given. Alternatively, azithromycin is also used. For the patients that develop neutropenia, you use GCSF, but not chronically. You just use to recover from the neutropenia, and then you stop it. Because chronic use of GCSF may predispose to myeloid leukemia. So you cannot use it on a long-term basis. And the bone marrow transplant that we had a full section here with Troy and Andy, and you already, it's the only cure available. The gene therapy is on the way. We will have a specific session on that, then we're going to see. So for now is what we have. So you have immunoglobulin replacement, you have antibiotics coverage for selected patients, the GCSF, and that's it. And bone marrow transplant. In my concept for our patient reality, so what happens in Brazil and Latin America? We are very heterogeneous population, and it's frequently hard to find a match. Additionally, what we have established is bone marrow transplant for SCID, CGD, Wiskott-Aldrich syndrome, but the hyper IgM patients are more recent in our knowledge, so we became interested in this about in 2007, so it was more or less 10 years ago. So what I'm showing is the work of the last 10 years. So it's something relatively recent in our medical environment. So we still did not develop enough experience to make comments on bone marrow transplant. We have a few patients that were transplanted, but what happens is that still the patients come later to diagnosis, and many of them, unfortunately, with organ damage, and then make things more difficult to transplant. So about the comments of Andy and Troy in the transplant in the morning, so looking to our Latin American patients, I would say, if you have it and you have a good match for transplant, you are confident in doing that. So do as early as you can. Because we have the experience of late diagnosis, and the late outcome without transplant is really hard. It's difficult. About the issues, therapeutic issues. So these are just general comments about the basic hygiene measures. As Andy has mentioned, once you go to a restaurant, you never know how the salad was washed, what kind of water, so you have to be careful, and this will bring you some limitations on daily activities. The antibiotic prophylactics may lead to microbial resistance, immunoglobulin replacement. Well, we all know about the side effects of immunoglobulin that may happen. The recombinant G-CSF, well, it's a risk for myeloid leukemia. The bone marrow transplant, yes, you have to deal with the graft versus host or with the rejection of the transplant. The recombinant human CD40 ligand, this was attempted earlier but had severe side effects, and the patients could eventually develop thrombosis, malignancies, autoimmunity, etc. CD40 molecule agonist antibodies, the same thing. The recombinant human interferon gamma, there was one case in the literature, and now we are proposing to start a trial. Then in my next talk, I will explain you this. And the gene therapy is still under development. So these are the perspectives on hyper-IgM. So it impairs both adaptive and T cells responses. With few exceptions, there is no clear phenotype-genotype correlation. Even with antibiotic prophylaxis and G-CSF administration and immunoglobulin replacement therapy, the patients are still susceptible to opportunistic infections. Patients treated with bone marrow transplant, though depending on the series of studies, you may have different outcomes. Then we have some results on recombinant human interferon. Please, this may be a future alternative for treating patients. We will work on that. And gene therapy is underway. Okay. So I will interrupt here and collect your questions.